Well, hello and greetings from Oklahoma City. It's my pleasure to present and give some brief commentary on probably one of the more exciting abstracts to be presented at this year's virtual ASCO meeting, which is the final overall survival results from SOLO2. And this was presented by my good friend, Dr. Poveda. And I'm going to just take you through kind of the background and the schema of the study. And so this is something I think those of us who take care of patients with ovarian cancer know all too well. Once patients' tumors recur after frontline chemotherapy, the interval of time the responses to platinum therapy, first of all, decrease with each subsequent platinum-based therapy. And then in the setting of a complete or partial response to that therapy, the interval of time before the next documented recurrence or progression gets incrementally shorter with each subsequent line of therapy until, unfortunately, these tumors almost always become resistant to platinum. So that's sort of the bad news. The good news is that, at least in the United States and in many parts of Europe, the prevalence of women who are surviving with ovarian cancer is at an all-time high. And this is despite no change in incidence and no change in mortality. And so why is that? Well, it's because we've developed active therapies for use at the time of recurrence. And so incrementally, each of those and better supportive care probably push out the progression-free survival and ultimately overall survival. And so because of that, showing an overall survival advantage in a treatment trial for women with recurrent ovarian cancer in the front line or in early recurrences has been very difficult, if not impossible, with one exception, and that was a modest OS improvement with bevacizumab in GOG 213. But otherwise, OS has been very difficult to demonstrate because of the long survival, and then in PARP inhibitor studies because of the impact of crossover. And so this analysis is particularly interesting because of that difficulty. And so, this, just kind of talking about the issue of crossover for this particular study is that we've known even pre-SOLO2 that PARP inhibitors are effective in women with BRCA-associated cancers, either germline or somatic. It's during the course of this particular study in recurrent disease, it became approved in frontline, now outside of BRCA, but certainly the first approval was in BRCA-associated cancers, and recently approved in the frontline for those with homologous recombination deficiency. So it's moved into the frontline, but during the life cycle of SOLO2, it was certainly approved for use in the recurrent setting as a treatment. And so patients who were on SOLO2 who subsequently recurred and had not received olaparib or a PARP inhibitor were able to obtain it or could obtain it on subsequent lines of therapy much more easily than at the initiation of SOLO2. So crossover became a much bigger issue, and appropriately an issue, during the course of SOLO2. And so there was some question as to whether or not we'd be able to show an overall survival advantage. And this just reminds you sort of what the SOLO2 primary analysis plan was. And this is a pretty old study now when we think about it. First patient on was in September of 2013, almost 7 years ago. The study initiated, but very quick to accrue. Last patient on in November of 14, and the primary data cutoff was in September of 16, and that was for the PFS endpoint. Just to remind you again, these are patients with BRCA-associated tumors only, and mainly germline. And use of olaparib versus placebo in patients with a PR or a CR led to improvement over a year, an improvement in PFS over that achieved without therapy or with placebo, and a very manageable and consistent safety profile as compared to other studies of olaparib. And so the next question, of course, is overall survival. We have a hint of overall survival from what we call study 19, which was a similar design but randomized phase 2 study, which showed a hint of overall survival that was not statistically significant for a variety of reasons, which have been previously presented. But there was some sense that overall survival was improved with the caveat of study 19 was done many, many years ago when PARP inhibitors were far less accessible as they are now. And so the crossover was far less than it was in SOLO2. And so would that hold? So this, just to remind you, is the study design of SOLO2. Again, platinum-sensitive relapsed ovarian cancer, BRCA associated. They had to have received at least 2 lines of platinum-based therapy and be in response to the most recent with either a partial or complete response. And that was one of the stratification factors, as well as the length of the platinum-free interval. And they were randomized to olaparib 300 milligram tablets versus placebo until toxicity or progression. So there was no set discontinuation point. Primary endpoint was progression-free survival, and that was very positive and already presented. But then you had these secondary endpoints, and we're going to talk about overall survival today. And this data cut point happened in February of this year, 2020. And it was planned, as you can see in the red box, for a point at which we reached 60% data maturity, or 177 events. There was a pre-specified adjusted overall survival analysis to adjust for the anticipated crossover to subsequent PARP inhibitor amongst those patients who were randomized to placebo. And then because of that, also there were planned, not necessarily pre-planned, but sensitivity analyses to try and correct for misstratification based on platinum, the kind of platinum-free interval and characterization of platinum sensitivity at the time of randomization. And there's also a pre-specified overall survival sensitivity analysis based on the type of BRCA mutation. And so these are just the patient characteristics. This has been presented before, and so I'm not going to dwell too much on this because it is basically what you would expect, mainly ovarian cancer, mainly high-grade serous. The majority were BRCA1, which is what is expected, about 65% versus 35%, and a very good performance status as was required by the study. But it's kind of half and half, complete response versus partial response. A little more than half of the patients came on with only 2 prior lines of therapy, so they're receiving this maintenance therapy as the maintenance following their second-line platinum, and about 25% came on as maintenance following their 3rd platinum, and then it was a pretty steep drop-off from there. So this is mainly maintenance in 2nd or 3rd line platinum-based chemotherapy. You can see the platinum-free intervals here. About 60%, or exactly 60%, actually had a preceding platinum-free interval of greater than 12 months, so particularly platinum-sensitive group. Only about 20% had prior bevacizumab. And about 50, interestingly, 16% of patients came on with partial responses that were actually measurable greater than 2 centimeters. So patients that had probably real disease at the end of chemotherapy were randomized to this study. This is just a disposition at the data cut point in February of this year. So you can just see that for the olaparib, patients randomized to olaparib, 78% of patients had discontinued treatment prior to the final data cut point. 92% of those randomized to placebo had discontinued. And then the various reasons are listed here. Disease progression accounted for discontinuation in about 50% of those randomized to olaparib, and 80% of those randomized to placebo. This is very consistent with what has been previously presented. But given the length of time this has gone on, it's interesting to note that 22% of women randomized to olaparib are still on study this many years later. Remember, the last patient came on in November of 14, and we still have 22% of patients on study, 8% of those on placebo. So here's the final analysis for overall survival. And really the take home here is that the median overall survival is improved by over a year, almost 13 months, as compared to those patients who are randomized to placebo. And this is unadjusted for the crossover, which was almost 40% of patients. I'm surprised it's not higher, but almost 40% of patients who received placebo crossed over to a PARP appropriately. And this is unadjusted for that. So even accounting for those women who went on to appropriately receive a PARP inhibitor in a later line of therapy, either as maintenance or treatment, we don't know that, we still see this overall survival advantage with a median overall survival of about 39 months in the placebo group to about 52 months in the olaparib group, with a hazard ratio of 0.74. So a 26% reduction in the risk of death with using olaparib in this line of therapy. Now, a lot has been said, and we'll continue to talk about the fact that the confidence interval around this hazard ratio hits 1, and so is, honestly, we have to say, technically not statistically significant. So that's true, but the patients live a year longer. And so I guess I would refer you, there's a great commentary that's written in March of 2019 in Nature called Retire Statistical Significance. I would encourage you to look at this commentary. I think this is one of the situations where I understand a p-value is a p-value, but patients live a year longer. And truthfully, I think this is real and we need to pay attention to it. Here is the adjusted curves. So this adjusts for the crossover and recensors them. And so with taking out the patients who subsequently crossed over to a PARP inhibitor, you see a median overall survival improvement of 16 months for olaparib over placebo, with a hazard ratio of 0.56 and a confidence interval that is statistically significant. And that's not unsurprising. But I think the more powerful curve is the unadjusted, which still really does show the benefit of using a PARP inhibitor, even with crossover. Using it earlier, patients live longer. I think that that is true and important to point out. This is time to first subsequent therapy. So these are patients in second or third line maintenance. And you know, when you do a clinical trial and you're doing serial scans, a patient may meet the progression definition because their lymph node is now 1.5, or you had a 5 millimeter increase, and so you're required to take them off the study, even though in real life you may have left them on because of some equivocal change in a lymph node. And so patients come off study on trials sometimes earlier than we would do clinically. And so this time to first subsequent therapy is trying to get at that. It's not an exact science, but it's trying to say, okay, you took your patient off because we made you. At this point, when did you feel it was necessary to start the next line of therapy? Because sometimes there's a big gap, or if it's just a lymph node, maybe you leave someone alone until you really needed to treat them again. And so looking at not just that progression-free survival, but how long in kind of clinical real life did it take you to go to the next line of therapy? So time to first and time to subsequent therapy, try to get at that clinical real life sort of curve. And so this is just showing you what that looks like for SOLO2, where you do see a very statistically significant improvement in the time to first subsequent therapy among those women who were randomized to olaparib versus placebo with a hazard ratio of 0.37. But also interestingly in this curve, sometimes it's nice to look at landmark analyses. And so you see that at 5 years, so these are patients who've been followed for 5 years. We followed these patients for far longer now. You do see 28% of patients randomized to olaparib remain without evidence of progression or recurrence versus 13% in those randomized to placebo. And so there are this small group of patients who you treat, with whom who receive platinum-based chemotherapy and likely are complete responders and do fine for 5 years. These are BRCA-associated cancers. And so certainly if we could identify that 13%, you would want to leave them alone. But thus far we cannot. And so, so not kind of offering this therapy is probably not the right thing to do. Trying to hope that your patient's in that lucky 13%. It's a little bit like selling a lottery ticket. So 28%, so over double the number of patients at 5 years still without recurrence with use of olaparib. You know, that's a clinically significant finding. Here's just another way of looking at things. This is duration of treatment exposure. So as I said, 22% of patients receive maintenance olaparib for over 5 years. And so you can kind of see in blue, those patients randomized, the percentage of patients randomized to olaparib who are exposed to treatment for 1, 2, 3, 4, and 5 years, and those randomized to placebo with the same kind of percentage of patients, which sort of is a surrogate for recurrence. If you're still on olaparib or still on placebo, you likely haven't recurred. And so at greater than 5 years, so not just the 5-year benchmark, even those that have been followed to 6 and now 7 years, you see 22 versus 9% of patients continuing on therapy, which is fairly remarkable in a patient population with recurrent disease. Here's the safety overview, and this looks very consistent with every other study of olaparib. You see fairly low rate of serious treatment emergent adverse events. In the primary analysis, it was 18%, 26% in the final analysis with more follow-up. Treatment emergent adverse events that led to dose interruption were about half of patients, and that's what we've seen. You have to hold the dose every now and again. When you're using olaparib, only 28% of patients needed a dose reduction, and 17% of patients had a treatment emergent adverse event that led to discontinuation. Now, this is higher than what was reported at the time of the progression-free survival, which was only 11%. So over time in cumulative use, you picked up a few more percentage points of patients who are discontinuing due to treatment emergent adverse events. So this is like nice long-term data about what happens over many, many years when we're treating patients, and it looks like about 17% will discontinue due to an adverse event. This is just a little more granular look at what the adverse events are. So the lighter lines are all grades, and the darker lines are those that are grade 3 or higher. And just as in really every other presentations, you see very common but low grade rates of nausea, fatigue, vomiting, and diarrhea, with really nominal percentage of patients who are grade 3 or higher. Really the only grade 3 or higher toxicity of note that happens with any kind of frequency is anemia, which is 19% of patients on SOLO2. And so those patients may need transfusions. From prior studies, it's probably about 3/4 or 2/3 of patients with grade 3 or higher. It's usually just grade 3 anemia require transfusion, but it's only 19% that kind of hit that mark. You can see the comparatively, not surprisingly, low rate of adverse events with placebo. And then here's the final analysis. So that was the primary analysis, 19%, and then here's the final analysis, very similar. You got 2 more percentage points of anemia with time, so 19 to 21%, but really no other big changes in the emergence of grade 3 or higher events with prolonged use. And that's very consistent with study 19. Now, I think this is, other than the overall survival, this slide is probably one of the more interesting ones to me, because the study should be commended for reporting this. This is kind of the thing we want to know is, do you see more myelodysplastic syndrome or acute myelogenous leukemia with continued use, especially amongst a patient population with BRCA-associated cancers, where you can expect they're going to be on PARP inhibitors for many years sometimes. And so this is really one of the first times this has been presented. And so we should take note, and as other studies start to result, accumulate this data. So we do see AML or MDS rates, and the primary analysis was 2%, was 4% in the placebo group. So we do know there's a baseline risk for these hematologic, kind of secondary hematologic malignancies to occur in our patient population, and it may be a little bit higher amongst those patients with germline BRCA mutations. In the final analysis, this is 8%, and then it's broken down. And so you see the patients that are during the safety follow-up period, 4%, and then after the safety follow-up period so it's not a treatment emergent adverse event, but sometimes after the patient discontinues therapy, there's an additional 5% there. But you can see in the placebo group, you pick up 4% more in that group as well. So over long-term follow-up, when you continue to follow these patients post-participation, the rate of AML MDS looks the same in both groups. So that may be that baseline rate. During therapy, we may have a little bit of a higher rate there. So I think this needs to get teased out a little bit more. The rate is still very low, but 8% over time in patients who were on the study and then followed for an after safety follow-up period is something we need to take note of and see if we can tease out who these patients are, what places them at risk, and whether or not there's anything we can do to predict who they are and mitigate that risk with potentially different decisions regarding therapeutic interventions. So this is pretty new data, but I think something that we need to pay attention to. So in conclusion, so SOLO2 is the first phase 3 study to report in the recurrent setting of PARPs, and there are several of these. This is the first one to report overall survival data for women with platinum-sensitive recurrent ovarian cancer and a BRCA mutation who have responded to platinum-based therapy and now are on maintenance. So clinically meaningful improvement in OS of almost 13 months, unadjusted for prior or for subsequent PARP inhibitor use. At 5 years, 42% of patients treated with olaparib were alive. 22% of patients randomized to olaparib are still on olaparib at 5 years. So the surrogate for that is that they have not progressed or recurred. And of course, as I showed you, the time to subsequent therapy is improved with use of olaparib. We didn't really see a tremendous increase in the significant adverse events and dose modifications, meaning interruptions, reductions, or discontinuations with cumulative long-term use of olaparib. There was a little bump up over time, which isn't unexpected, but it wasn't a tremendous increase, which speaks to the safety of long-term olaparib PARP inhibitor use. I do think that the AML-MDS story is evolving. This is, again, I'm really glad that the authors presented this because we need to be talking about this risk across all of the PARP inhibitors, and as the other studies will report their overall survival relatively soon in the near future, especially in non-BRCA associated cancers, it will be important to put all of this data in context. And I do think that Dr. Poveda spoke to this well at the ASCO presentations, that while we need to pay attention to this, it does need to be taken into context. These were relatively late onset. We do see rates in both placebo and olaparib treated patients. And so the risk factors, cumulative therapy, there are lots of things that need to be teased out in terms of assessing risk here before we can really understand sort of what the true risk of use of olaparib or niraparib or rucaparib is in this population from an AML-MDS risk. So this is the first piece of long-term perspective data we've had, very helpful to sort of set some groundwork as we move forward and continue to evaluate this important side effect. But I don't think meaningfully changes the perception of risk or benefit for this agent, which is still very much favors benefit. And as Dr. Poveda did, we always have to acknowledge first all the patients who participated in SOLO2. It's nice to know that many of them, almost half, are still alive, and almost a quarter still benefiting from their participation on study, and so hopefully are very proud of their participation in improving the lives of women with ovarian cancer. Really, I think the importance of this really can't be understated. It's an overall survival advantage. It does, the analysis of subsequent therapy and the continued benefit of use of olaparib, even with crossover, I think reinforces the idea that the earlier you use PARP inhibitors, the better, and the longer lasting the benefit is, which probably, and I hope, will result in a similar story for our use of PARP inhibitors in the front line, but that remains to be seen. I think some of the questions surrounding SOLO2 just really relate to its relevance, a few years from now when most, if not all, women with BRCA-associated cancers at least will already have seen PARP inhibitors in the front line. Hopefully many of them are cured, that's our hope, but some will still recur, we know that is true. And if they recur 5 years later or 2 years later, is this still a relevant option for them? or do we need to reconsider kind of other maintenance strategies for this patient population for whom we expect many, many, many more years of life. So I think that's sort of the outstanding question moving into the future with SOLO2 for patients that are still PARP naive that fall into this criteria. This is absolutely the standard of care that they should be offered in the future when they're PARP pretreated patients. I think we have to answer those questions. And fortunately, we have ongoing studies such as OREO and DUET, which is about to launch, which will be looking specifically at women with PARP exposure in the past and retreatment with PARP in the maintenance setting to really get a sense of potential efficacy, resistance mechanisms, and better strategies for taking care of those patients in the future. So it's exciting to know that those studies are already ongoing, so our patients won't have to be in a data-free zone for many, many years. But an exciting paper, probably one of the best papers at SGO or at ASCO, and very proud of the study team. Thank you.